I'm now going to talk about the initial adjustment program for the AP bands. This next slide shows an AP standard band with 6 mils of saline in it. You can see the characteristics of the band, the omniform technology, and the way that there's a 360 encroachment upon the lumen. When we prime the APS band in theatre, most surgeons prime it with saline and allow the saline to run out at room pressure, and this leaves about 2.5 to 3 mils within the band. Some surgeons prefer to remove that fluid if they've had a few patients who've obstructed, so the amount that's in the band when we come to do our first adjustment can be variable. As we spoke about earlier, the first adjustment's usually done at 4 to 6 weeks, and we only adjust the band if the patient has now become into the yellow zone, which they would typically be in. That is the zone where they're hungry, looking for food, eating more, eating normally. So when I'm making the first adjustment on an APS band, what we tend to find is 2.5 to 3.5 mils in the band. So when we make that first adjustment, I add, and the patient's in the yellow zone, I add 1 mil, and that brings them up to 3.5 or between 3.5 and 4.5 mils in the band. I like to review regularly. I like to see them every 2 to 4 weeks and assess their hunger, their diet, their symptoms of obstruction, etc. And if they're hungry and eating easily and they're not obstructed in any way, I may add another mil. If they're getting some restriction but they're very hungry, I'll add 0.5 mil, and of course if they're in the green zone I won't touch them. I never touch a patient who's in the green zone and satisfactorily losing weight. So subsequent adjustments, once you've got to about 4.5 mils in the APS band, need to be small. 0.5 maximum down to 0.3, and even 0.2 mils can be used at times to get a satisfactory adjustment and keep people in the green zone. I aim to get people and keep people in the green zone over the first 2 to 3 months. Go slowly, adjust often, particularly if you're early in your experience with this. After doing an adjustment, I ask the patient to drink a small glass of water. I want to see them drink it quickly, and I want to see it go down with ease, not obstructing at all. I advise them to grade up to a normal diet, a normal lap band diet over the first 24 hours. Some liquid, something soft, and gradually up to lap band friendly foods. I know people have different views in this, but I've always found that just grading up over that 24 hours has been fine. Patients must always be welcome to return if the band was found to be too tight, and we aim to achieve about 50% of excess weight loss by 12 months, but we can change that depending on expectations and depending on the patient's condition. We know that on average we achieve 40% in the first 12 months. We are able to obtain an expected weight loss, maximum weight loss, at 18 to 24 months after band placement. Remember, the usual fill volume is around 5, 0.3, 5.5, and the standard deviation about 1.2, 1.3. So it's a fairly narrow range. Go slowly when you're in that range. With the APL band, I use exactly the same principles. I tend to add 2 mils at the first adjustment, and then increments of 1 mil if in fact the patient is hungry and looking for food, until I get to around 7 mils, and then I'll reduce it to half. Of course, people have slightly different programs, but once we get into that action zone of 7.5 or more, reduce your fill volumes to 0.5 or 0.3. We want to avoid patients becoming overfilled, over-obstructed, and always tell the patient that being overfilled is a problem. Now, why do we need to go slowly with our adjustments initially? Why is this incremental effect necessary? Well, I think we all experience what happens, that is the initial adaptive effect of filling a band. If we simply took AP patients and put 5.5 or 6 mils in their band, most of them would be very uncomfortable and obstructed. And we see this gradual adaptation process. This next figure shows us that adaptation process, and we see a patient when they have the surgery, they're often in the green or high green or red zones. After surgery, they're on a liquid diet, they're not hungry, they're satisfied, and over the subsequent weeks, 4 to 6 weeks, they become quite hungry, as if, many of them say, feels as if my band isn't there. We do our first adjustment, and you'll see there that we've extracted 2.8 from the band, and we've added just 1 mil in the first adjustment. We have now a total extractable volume of 3.8 mils after our first adjustment. The patient's now back into the green zone, back up near the red zone, and over the subsequent few weeks again drifts down to becoming, they're adapting to the band, they're adapting to that restriction. Our second fill volume is because the patient's hungry and looking for food, we add another mil, up to 4.8 mils now with the second adjustment, and they're back in the green zone, they're back on that border between green and red, and over the next 4 weeks they come down into the area between the green and the yellow zone. Third adjustment of 0.5 mils brings them up to what we find is the mean volume, 5.3, and there they are, satisfied within that, and staying within that green zone. So this initial adaptation is very important. People have used X-rays and pressure to try and overcome it, and they find they need the series of adjustments to get it right. We can see now why vertical banded gastroplasties and other fixed restrictions were so difficult for the patient, because they were either too tight, a bit loose, or just right, and it was hard to get them just right. This next figure actually comes from some data from Allergan, and when we put my fill volumes on it, and you'll see there the mean volumes and the standard deviations for both the old bands and the new bands. It's interesting that now these new bands have a slightly longer imprint on the stomach. They actually are slightly more open. They've got a greater surface area or exposed area or stomal area when they're in the green zone. It's probably why these bands are a little gentler and why we find less obstruction with the AP bands. The question to the US faculty, the total care faculty, was how many adjustments do you need to get into the green zone? And the average number was 3. Some are achieving the green zone in 2 adjustments, some needing 4, and some needing 6 or more. But you can see there 2, 3 or 4 adjustments to get into the green zone, pretty typical for multiple practices in the US. Why is X-ray not a good method of measuring the correct band adjustment? And I mean X-ray alone. It doesn't measure hunger, satiety, red zone symptoms, or weight. It may predict symptoms of obstruction. It may allow us to account for this overall initial adaptation effect, although the experience says otherwise. And of course, you know that the band restriction varies from hour to hour in the day. So X-rays alone are not a good way of deciding how to adjust a band. X-rays, on the other hand, are terrific at a number of things. They can help us find the port, a deep reservoir that's difficult to find, and they're essential when looking and diagnosing complications, in particular slippage, symmetrical pouch dilatation, or in fact distinguishing a band that's too tight from a complication. It's, I think, critical to understand that the band needs to be just right. I use the term no pain, no pain. If it doesn't hurt and you're losing weight and you're satisfied, it's good. Small adjustments within the action zone are critical. Don't be afraid to use adjustments of 0.2 or 0.3 in size, and to do so accurately, you'll need a small syringe, a 3 ml syringe. Instead of measuring the whole lot of the total extractable volume, you know it's 5.5, you're adding 0.3, call it 5.8. It's only when you suspect a leak in the band that you need to go and get a larger syringe and take the whole amount out. If you find some missing and it's a small amount, don't go and correct for it. It may actually still be in the band, and sometimes we get people into the red zone very quickly when we think there's some missing and add. I think if you find fluid missing, we need to confirm on several occasions that it is missing before assuming that there's a leak in the system.